Good afternoon, everybody. Thank you very much for joining us here today. We're excited to get back into the run of things, and I hope everybody had a wonderful summer and is ready for lovely quality and value-based care moving forward. Let's get started. A couple of things. First off, hi, Lauren Patrick.
Hi, Mike Lewis.
Lauren and I will be guiding you through this presentation today. So feel free to ask your questions, which I'm going to get to on the next page. We have the ability to answer your questions. This is a very, very long webinar with a lot of detail in it. So we may not get all of the answers out during the presentation, but you will be able to get most, if not all, of the answers to you by the end of the week. Lauren and I make sure that there also is a handout section here as well. You can that's going to have the slide deck in it so that you can grab that. I will email everybody this afternoon with the presentation as well as the slides for you to have. All right, so today we're going to review changes to traditional MIPS, the enhancements to MVPs, and then also what's new with the APP and lots more along. Lauren will be chiming in throughout and adding some color to the details that I'll be providing throughout the presentation. So first of all, from the proposed rule objectives, they really have three main areas they concentrated on. Alignment, stability, and feedback. With alignment, we're looking at bringing all of the programs together, MIPS, MVPs, the different APM performance pathways, and so forth, all together within the program so that, it reduces the burden as people move from program to program and increase their exposure into value-based care. Limited changes to the overall program. You'll see throughout this, there is nothing earth-shattering from a change perspective in any of the proposed rules and the information that they share. And then something that I saw more of, and maybe not necessarily more, I think what I saw is a lot of, you know, it was in front of your face that they're asking for more information and requesting you to give them feedback so they could build these programs in a way that works for not only them, the patients, but also the clinicians and the practices that are doing these reporting. Uh, the Innovation Center is part of the growth of these value-based programs, and they have a strategy that they've put out there, and that is improving the health of Americans and protecting taxpayers. As you've come aware, a lot of the programs that they bring out have to do with the quality care, access to their data, improving their care, and also reducing the costs. So, preventing disease through evidence based practices, empowering people with more information to make better decisions, and then driving choice and competition, really allowing patients to understand who's the best at what and where they can go to get the treatments that they need. I'll have little orange or peach, I guess it's peach boxes down at the bottom of the screen here that have requests for information throughout the throughout the slide deck. Here they're asking for people's feedback on how they can measure overall health, happiness, and satisfaction in life, and it could include aspects of emotional well-being, social connections, purpose, and fulfillment. I think that is where they want to drive these programs, and that is to have healthy patients overall. A couple of little things that didn't change too much to start us off. Uh, Everything from the proposed rules shares that the categories and the category weights are going to remain exactly the same as they've been in 2025 to 2026. Eligibility is going to stay exactly the same as it has for I guess we're probably going on 6 or 7 years at this point where it's been 90,000 in Medicare Part B charges, 200 plus Medicare Part B patients, and 200 covered professional services for eligibility for the MIPS program. As well here for the performance threshold, they have decided to keep it at 75 for 2026. That's been the same since 2022. And then they actually put into their logic that they were going to keep it going through 2028 with the idea that they can make changes based upon any uh, changes within the actual program itself. So they do hold the rights to make the changes, but they want to put it into law that they're going to keep the performance threshold at 75 for these years. I'm going to throw it over real quick to Lauren for her to introduce a new model called the ambulatory specialty model. Lauren? Lauren may be having some difficulties with her sound right now. So I'll continue until she can get that worked out. So first off, hold on, let me. Lauren, are you there? All right. Well, she gets that worked out. I'm going to continue going on here. So the new model, and we're going to do a webinar that's based on this. When I started to build the information for this presentation, it was 12 pages or so of just about this model. So we decided to pull it out and have another presentation on this in the coming weeks. So this model is about enhancing quality of care and reducing cost, specifically for two chronic conditions: the low back pain and the heart failure. Uh, and those percentages there that you see are the percentage of A and B spending throughout in history, 2.7% and 3.5%. Drives competitions between clinicians to reduce cost. It's going to be a 5 performance years, and it includes all the MIPS categories. I think the big thing from the program is it's going to be almost like an MVP, but it has the ability to force certain quality measures, improvement activities, uh, and cost measures, while where everybody can get the same exact measures and are compared apples to apples, instead of right now where you have more choice. All right, we're gonna dig straight into quality reporting and keep on moving here. So quality reporting, some of the key aspects we're looking at: data completion threshold is going to be exactly the same as it was in the previous year, and they're also planning on maintaining that through the 2028 performance year. Measure inventory, adding 5 new MIPS measures, eliminating 10 MIPS measures, and making substantive changes to 42 measures. I think I hear Lauren. Lauren, are you there?
Can you hear me now?
I can hear you now.
Awesome.
All right,
Okay, I'm ready.
good.
Sorry about that.
No problem. All right. So there are a lot of details in the coming pages and throughout this presentation. I'm not going to spend the time of driving into each one of the words that are on this page, but each time I'll share a thing or two that I found important from this. So these are the new measures that are coming across. There are 5 new measures for 2026. I found it very interesting that they talk about no more process measures and reducing process measures, but 3 out of the 5 new measures that they have are process measures. They do kind of reach throughout the different specialties. So unlike in previous years, I think what you saw were a lot of measures that you'll see 3 measures for ophthalmologists that all came out at the same time, or you'll see 3 measures for a certain specialty. This year they kind of spread out, and the stewards are very different and come from different areas. The quality measures to be removed in 2026, there are 10 of them, a couple of new ones, as you'll see. Uh, each one has a reason on the right-hand side for removal. If everybody is unaware of what a topped-out measure is, it's basically measures that practitioners and clinicians, I'm sorry, have been reporting for a long time and have really done well, where there could really be no change in the quality outcomes. They're basically scoring 100% across the board for a number of years. But then you'll see down at the bottom, there are a couple of new measures that are coming out, and you're going to see familiarity with this concept throughout the entire presentation here, removing 487 for screening for social drivers of health, removing 498, which is the continuation of that measure with a connection to a community service provider, and the removal of the adult COVID vaccine status measure. You'll see that they are removed across the board in a number of fashions as we move on. So here are substantive changes for the year. My favorite word, substantive changes for the year. I think here what we have is a couple of the things I want to point out. There definitely is a practice from CMS this year to get ECQMs and CQMs more aligned in what they are tracking. You'll see a lot of changing in time frames within 12 months to the measurement period. Here, a couple things that I wanted to point out is measure 47. They're going to get rid of the claims measure, but not the CQM measure. 117, however, they are planning on removing the CQM measure due to it being it topped out. Preventative care and screening for depression is another one I wanted to point out here. Now the ECQM collection type to match the CQM collection type is going to be able to include pharmacological interventions, so making follow-up plan necessary. Basically, what that's going to say is if you have one of the pointed out pharmacological interventions, that's basically going to say the patient is depressed and a follow-up is needed. From this page, as we go on, what you'll see here that I wanted to really point out and share is that there are changes to each one of these measures. Then a couple of the ones on this page are about telehealth. The one I wanted to point out is measure 441 and the changing of what a normal blood pressure is from 140 over 90 to 130 over 80. I think that's going to change, change who you have to answer those questions for each one of these measures. The last page has a couple more interesting ones. I want to point out on this page that hepatitis B vaccine was added to the adult immunization status. And then the two measures down the bottom, which are only available in MVPs and the APP or ACO reporting, the breast cancer screening measure, that's a really big change, is where the ECQM collection type is going to be moved to 40 to 74 from the 50 to 74 age range. So that's a big change for that measure for the ECQMs, adding 10 more years of patient age to those numbers. All right, last one. Not many people pay very close attention to the measure sets, the specialty measure sets that are out there, but to provide you with this information to show you in detail of what measures are being removed, added across each of the specialty measure sets that are there. You'll see a theme, obviously, last year, 487, 498, and 508, which are the SDOH measures and the COVID measure. Were all added in the 2025 final rule, and they're all being subtracted in the 2026 proposed rule. I am going to throw it over to Lauren for a quick follow-up.
Hi, Mike. So yeah, more and more, I think that CMS is looking to align the quality program with a lot of what's happening in what we used to call the ONC, Office of the National Coordinator, and now it's called ASTP, I think. But trying to integrate a lot of the technological advances that are being made kind of on the other side of the house, and align the measures with both fire and DQMs are coming. And I think that we're going to see more and more of a push towards that as we go forward. Obviously, technology challenges arise, right? Because as much as we've talked about fire over the years, reality and planning are two different things. And, we're ready at Health Monix to take fire data and to report fire data, but implementation and coordination with across all of the various EHRs and data sources is a true challenge. And so, as much as CMS can, they're pushing it, but I think they realize the technological hurdles that we're all going to have to overcome in order to make that a reality. Just like we had with QRDAs and CERT and all of the technology advances that we've worked on over the course of the last 15 or so years.
Great. All right, one more from you on the next one here, Lauren. Following, basically closing out the quality section of our presentation.
So yeah, so the good news is that CMS is really for traditional MIPS. They're not changing a lot of the scoring. They did make a change last year, well, 2024, on the cost measures, which we may cover in a bit. But the actual scoring is the same. Thresholds are the same. Categories are the same. Reporting mechanisms are the same. As Mike said, I think that the changes to 112, we've had a lot of folks get confused, if they're reporting the CQM versus the ECQM, what is the patient population, et cetera. So I think that these are good changes as they're working to align them. And I am actually surprised that CMS, my personal statement, that they're not removing more measures. They have said more and more that they're pushing towards this universal quality set, and we really don't see a lot of that happening here. I think the measures that they're removing are either because of reporting challenges like they're topped out, or because they don't align with the administration's directives to not focus on social determinants and not focus on COVID vaccines.
Great, thank you, Lauren. All right, now we're going to pop over to improvement activities. Once again, not terribly a lot of changes in here, but want to provide everybody with an overview of those changes. New and revised improvement activities for 2026. You'll see that they're adding 3 more uh, improvement activities here, very spread out in different areas of expertise. I do think that what you'll see a lot in some of the rule here, if you wanted to dig in and read a lot of it, I don't don't do that. Patient safety and use of artificial intelligence. I think you'll see artificial intelligence being a worry, as well as cybersecurity and so forth of CMS more now than ever before. They are planning on making a change to the behavioral mental health measure, and as well as removing the achieving health equity subcategory and adding advanced health and wellness category. On the next page, I'm sharing these are the measures that they're doing away with. If you saw, if you were in our email uh, chain and have the ability to receive our emails from our team, we did share that CMS retroactively removed 8 improvement activity measures for the 2025 year, all surrounding the social determinants of health and so forth. You can see them here. 5 of the 8 have to do with achieving health equity, and then population management around COVID vaccine, the other ones. So CMS is saying that they are removing these activities since it doesn't demonstrably improve patient health outcomes basically across the board. So that's really it for IA. We'll move on to cost. For the cost category, once again, there are no changes in the cost category measure inventory. So they're exactly as the same as they were last year. Last year, they added 5, I believe, 5 new measures, but there is no changes or no additions, subtractions in this year's measures. Uh, there are a couple things I did want to cover, though, with costs. One is the introduction of a 2-year delay for cost measure adoption. So in the past, CMS would introduce a measure and score clinicians immediately on it. They found that this really doesn't give you enough time as a clinician to understand the measure, see if you're being attributed lives and so forth, and being able to work on improvement activities for it. So they are proposing that there is going to be a 2-year informational only period. So the first year, they'll have the measure into 20, so they'll have the measure, they will introduce it into the final rule. Then you'll have 2 years where you'll receive directly information regarding your um, cost scores for those two measures. So that's not going to be publicly available. It'll only be available to you as a practitioner to be able to see what your scores would be. And then after that 2 year feedback period, the measure will be added to the cost category inventory. So from my understanding with this, we're not going to see a new cost measure uh, given out to anybody until 2028 at the minimum. So they'd have to introduce things
2029, actually.
2029. So there are not going to be any new ones till at least 2029. I'll let Lauren fix my math. All right. Next on here is that proposed modifications for the TPCC measure, which is the total per capita cost. That is the most popular measure with the most attribution to the most amount of clinicians. And this is an issue that has arisen for me for a long time. And their way they're going to fix it is interesting, and I hope that it does go through. Basically, what it's saying is that triggering event from a clinical group, the second visit can be either provided by the same clinician or another clinician. So that's the current. What they're saying for the proposed is that the second visit can only be done by the same group. So the patient needs to see the same group twice. Triggering event exclusion criteria, it requires only the first visit to be provided by a clinician that isn't excluded based on specialty. So this is the only measure where there's exclusions based on specialty and only has what CMS calls either a primary care or primary care adjacent specialty. In the future, or for 2026, they're saying that it's going to require both visits to be provided by a clinician that isn't excluded, so not just the first visit. And then a big one for the specialists that I've worked with in the past and which has kind of hurt them are that nurse practitioners, physician assistants, and certified clinical nurse specialists have all been included in TPCC in the past. So even if they work at a GI practice or a dermatology practice or so forth, and they had claims from a Medicare patient, they could be attributed as their primary care provider. They were looked in the same light as a primary care provider. The way that they're thinking of fighting that in the proposed specifications is that nurse practitioners, physician assistants, and certified clinical nurse specialists are going to be excluded from TPCC only if they're part of a clinician group where every other clinician in the practice is excluded based on specialty criteria. So it's not a clean swipe of getting rid of those clinician types. It is just the fact that if they work in a practice that would normally be excluded as a whole, they will be excluded. So that's a big win for some small specialty practices. So I'm going to kick it over to Lauren to kind of review the cost changes.
Sure, Mike. So as Mike said, there's no new measures for 2026, which means the first year there would be a new cost measure would be 27, and those would be excluded from 27 and 28. So you would see that being attributed to providers in 29. So that's why I jumped in there. Um, the TPCC change is huge, and it's something that a lot of specialists, e.g., dermatologists and ophthalmologists in particular, have been complaining about for years because the intent of, I believe, the TPCC measure was by excluding like derms and ophthalmologists, that they were not going to get the measure attributed. But what would happen is because mid-levels are not assigned a specialty, they would get folded back in, and folks in the specialty groups would be getting those measures. So that's a huge win. CMS heard everybody, and yay, they're gonna change that. So a lot of groups won't see that anymore. I see applause. I agree. It was the right thing to do. And then also, with the two visits being within the group, we just saw a lot of attribution that really shouldn't have been. And the intent of the measure should be that you're assigning patients, you're attributing patients to providers that are really overseeing the patient as a whole patient. And then the surprise attribution, like I said, that's that has to do with the fact that measures like when you guys see your 2024 reports, which should be out any day now, you're going to see measures you haven't seen before. And you're going to go, oh, that's an interesting measure. I wish I would have known about it. Maybe I could have done something about it. So they're trying to alleviate that sort of surprise. So I think it's all of this is good. All of this, I believe, is CMS listening to feedback. Now, there's a lot more feedback that a lot of us have given, but certainly it's a start.
Great, thank you, Lauren. Ooh, multiple claps on that one. Man, I haven't gotten any claps today. All right. So as we move on, we're going to move to promoting interoperability. Uh, Thank you. Promoting interoperability key proposal. You guys are the best. I love it. All right. Promoting interoperability key proposals. Security risk analysis. Adding a second attestation requiring yes, saying that you are implementing the security measures and to reduce risks and vulnerabilities. Basically, for the previous umpteen years that we've been doing this, it just asked you to say, yes, I've done a security analysis, security risk analysis. Sorry. Now they're saying, okay, great, you did it. Are you doing anything to fix what you found wrong? And that is what you're going to have to say yes to moving forward. The Safer Guide updating from the 2016 version to the 2025 version. No big changes in there besides language within it. Public health and clinical data exchange, adding an optional bonus measure using TEFCA, Trusted Exchange Framework and Common Agreement, adding that extra measure onto your bonus opportunities for the public health and clinical data exchange part of promoting interoperability. Establishing a measure suppression policy. So this is new, very similar to the ability for them to suppress a quality measure over the years where new medical information or a change or an error had occurred. They can choose to suppress the measure to keep it out of reporting for the year. And then uh, they're also recommending, while adding that policy, the reason is they want to suppress the electronic case reporting measure for 2025, which we'll dig into on the next page. The request for information, they're looking for feedback on possible changes to the PDMP measure. The change will move from an attestation, so that you're yes, no, to a performance-based numerator and denominator measure. I think, between that and what they're asking with the security risk analysis, they're basically saying that the ability to attest yes to something is not enough anymore, and they're looking for action on what you're trying to do. The other part for request for information is the change in current attestation-based measures in the public health and clinical data exchange objective. Once again, how do we track and how do we know that clinicians are utilizing these information exchanges to increase public health? So you're going to see the ability, I think, cross-cutting and promoting interoperability now to basically saying that it's not enough to say yes. You need to actually show what has been done in it. So from suppressing the the electronic case reporting measure for 2025, so this would be backdated to this current year's program. So the issue is that the CDC has temporarily paused electronic case reporting registration, onboarding of new healthcare organizations, and their plan is to establish a more robust system that is going to allow automation into the process. So with that in hand, anybody who hasn't started utilizing this yet wouldn't have been able to answer yes to this question. So the current status and the current rule says that in year two, you need to move on to option two. Since it was mandatory in 2024, everybody did option one, at least option one in 2024, and that would put anybody but new TINs in the option two part of this, which is not able to work if you're looking at doing that right now. So what CMS is looking to do is suppressing that measure where you will still need to attest to it. You can attest a yes or a no, but the answer will provide the same result. You'll get credit for doing it or not doing it, but it's not going to hurt or help your score. All right, Lauren, on you.
So again, as I sort of intimated prior, I think that CMS is really starting to take a look at the PI category. It's kind of in a sleeper category. They've been making small changes to it as we move forward. I think that there's been enough movement, like I said, on the other side of the house, that they're seeing that they're going to have to up their game a bit. I do think it's interesting, and we'll talk about it in the ASM webinar, that on the whole, I think CMS is starting to de-emphasize PI a little bit as you look at some of the new models that are coming out. But yeah, it'll be interesting. It'll be interesting to see how much emphasis they place on this, and like I said, fire and implementation of DQMs and things like that.
Great, thank you. All right, we're going to move on to MVPs. So there is CMS's strategic direction for MVPs. They are saying they are the future. I think we've kind of been talking about them for so many years now. We're just, ready for it at this point. They are reinforcing that MVPs are the preferred participation framework, and they still have plans, but they haven't updated any timelines or so forth to get rid of the traditional MIPS in favor of MVPs. So the emphasis is on continued gradual transition. And what you'll see is there is some simplification and alignment in the programs that help reduce some of the burden on clinicians and groups to be able to report on MVPs as they realize that over the last couple of years there have been a number of uh, parts of the program that are not as attractive to a group to be able to report on. So, focusing on clinically cohesive measure sets, promoting team based care, aligning with the value based care principles, including cost, quality, and pop health, and then encouraging interoperability and digital measurement. Those are the key pillars of MVPs, and they will still continue to be. All right, what is new with MVPs? First off, there were only 2,000 groups or clinicians that registered for MVPs in 2024. I think they're seeing that slow adoption due to the measure choices available for people, the lack of understanding, and the lack of any type of mandatory MVPs. CMS is proposing to add 6 MVPs, which we'll review later. Modifications to all 21 existing MVPs. I think you'll see similar traits as you've seen the changes in quality and improvement activities. CMS is proposing to change health specialty designations, and we're going to spend some time on that for subgroups and that are assigned. They're asking for requests for information. CMS is considering introducing a core element subset of the quality measures, which is interesting. And we didn't go into detail on this, but basically saying that, here's your MVP. You have to choose 4 measures. However, we're going to say you have to do this one measure, or you have to do this second measure, or you have to do one of these 2 measures, and then you can pick 3 others. It's really open right now, but they are planning on doing that because they're still, MVPs are little mini MIPS, really. It's not really making everybody do the exact same thing. Some of the MVPs have 20 plus measures in them. So if every one of the groups that reported on a certain MVP did a different 4 measures, how can you compare that information? So when it comes to specialty composition for proposal for 2026, this is the big change. The big change here is in previous rulings, CMS finalized that starting this year or 2026, multi-specialty groups that want to report MVPs would have to report as subgroups. So that's the it's been on the horizon. We've known it's coming since MVPs got started, but it's finally here, and they're not backing down from it. So the proposal would be that to change it a little bit of how that happens, groups would have to self-attest to their specialty composition during MVP registration. They can attest that they are a single specialty group. They can attest that they are a multi-specialty group. And then they can also say that they're a multi-specialty group as a small practice. So what you will see is the small practice multi-specialty groups, those with 16 or fewer clinicians, are still going to be able to report as an MVP group. So the subgroups are available if they wanted to, but they're only an option for small groups. For the large groups, they will be mandatory, but instead of CMS saying, hey, these are the codes that you build on, or this is your specialty that's listed in PACOS. Here, you get to say, these are the type of patients I treat. This is my specialty. And maybe if you have a bigger group, but they all treat the same patient base, you can do one of the MVPs that associates with all of the group, not just a single specialty. So as an example, what it will look like is multi-specialty practice MVP examples for 2026. Here we have one large multi-specialty group that can report in many, many different ways. So this is not an APM entity. This is not a virtual group. This is a multi-specialty large practice. They can report traditional MIPS as a group. They can report traditional MIPS individual reporting, and then they would have to split their group up. And in this case, I have a urologic care, kidney care, and GI care that all work in one practice together. And they would have to do separate subgroups if they wanted to do MVPs. They are not being forced to do MVPs, but if they wanted to participate in MVPs, they will have to do it as a subgroup. We do have other presentations that we've done in the past strictly on MVPs. If you want more detail on that, highly recommend going to healthmonics.com. In the top right, you can click on resources, webinars, and look at our MVP webinar from last year. Really goes into detail on how and what MVPs and how you will report on them. Proposed changes to existing MVPs, not going to spend a lot of detail and time on here, but measure 487, the social determinants of health, is being removed from every single measure, as well as the improvement activities for that were around the social determinants of health and health equity, as well as the COVID vaccine measure, were all eliminated. The biggest changes is that in the gastro care, they're adding a new measure around HCV, and they are adding a cost measure as well. So GI has a bunch of changes for 2026. Uh, Here, what you'll see is the same thing that you saw on the previous page. The kidney health one does have a new measure that they're planning on adding. The infectious disorders is adding new measures, as well as a bunch of cost measures, but very similar, same across the board for all of these MVPs, with not terribly a lot of change. So the new proposed MVPs that are out there, there are two radiology measures that are being, two radiology MVPs that are out there. That's a big call for radiologists, as they really haven't had terribly a lot of measures to work with throughout the year. So it should be exciting for them to have that opportunity to report a radiology MVP. There is a neuropsychology MVP, which I'll tout on our back, includes the MBHR measures in conjunction with our work with the American Psychology Association. So they are some measures that we have, and you can utilize them through our system for neuropsychology. There is a pathology MVP, another group, by the way, pathology like radiology, or some of radiology where it's not patient facing, and they have had limited measures for a long time. Podiatry MVP is big, and then vascular surgery MVP that is also in there. So there are a lot of MVPs that are coming, and a lot of ideas for change of what MVPs are going to look like moving forward. Lauren, it's on you.
Um, yeah, I'm not sure that I have a lot to add. I think that, um, again, CMS is really trying to react to the issues that clinicians are bringing up. So, their problem was if they go into the current systems, which indicate the specialties of providers, which is kind of how they were going to do MVPs, the problem is the data is not always aligned with what happens in reality. So what they're trying to do is to allow organizations, groups to say to CMS, well, this is really our cardiology practice, and these are all the clinicians that belong in it. These are all of our radiologists, and these are the clinicians that belong in it. So choosing your specialty is something new that they're putting forward this year, and again, really trying to allow a better alignment of the MVPs with the reality of what's happening in the practices. Um, they are starting to lay down a few requirements, like if you're a multi-specialty group, you're going to have to split it up and you're going to have to create subgroups, groups going forward if you want to report MVPs. And they did add 6 new ones. I believe there's even more in the works. I know a lot of people we work with are proposing MVPs going forward. And I do think that the other thing that's interesting is this idea of core measures. They realized that they were trying to get the MVPs so that they're measuring, like to like in terms of practices and providers. But with some of the MVPs having as many as 24 measures, that likeness isn't happening very strongly. So they're going back to the drawing board a bit and going, okay, so how do we really make these so that we are measuring apples to apples here? And I think that's a challenge. The problem is there's so many different specialties, right? Even if you're an ortho practice, kind of where are you working within that ortho practice, that specialty? And not everybody can use a hip replacement measure as their core measure. So how are they really going to align apples to apples is the challenge. And they're proposing some initiatives, but we're not sure it's quite going to work. So if anybody has any brilliant ideas, respond to the proposed rule.
Thanks, Lauren. And a bunch of great questions actually came in real quick, and a couple of them are one hitters. So I'll take them while we're here and talking about MVPs. One, there is no minimum clinician for an MVP subgroup. It could be a single individual provider can do an MVP. The one, if a clinician registers for an MVP they're reporting, do they have to report it? No. Registration is intent. You still can report traditional MIPS even if you sign up to do an MVP. And I highly recommend that if you're doing an MVP, you should try to report both the traditional and the MVP at the same time, and CMS will give you your highest score. Another thing to share here too is that if you are MIPS eligible, MVP is just another path that you can use. You do not, there is no penalty if you don't do MIPS. MVP will replace that. So there is a deadline on it as well. I'm gonna keep on it. There is a deadline for registering for an MVP. I believe it's December 1st this year. Last year I think it was November 30th, but I can confirm that later as well. So appreciate the questions, love the questions, but we still have a bunch to get through, so I'm going to keep going right now. All right, on to MSSP and your Medicare Shared Savings Program. There is a couple of updates. Facts here are 477 ACOs. That number has been pretty steady year after year for the last 3 or 4 years, but the number of healthcare providers, 650,000, has increased pretty dramatically over the years, and then 11.2 million assigned beneficiaries that are in the program. The big changes are the removal of the health equity adjustment, which is going to be retroactive back to the 2025 performance year. And then I think the real big change is changing the definition of what a Medicare, a beneficiary eligible for Medicare CQMs. And that once again is going to be retroactive back to this year. And we're going to go over that on the next page. So what is a beneficiary eligible for Medicare CQMs? They are planning on updating the definition to include that a Medicare patient who has at least one claim with the data service during the measurement period from an ACO professional who is a primary care physician or has one of the specialty designations, or who is a physician assistant, nurse practitioner, or clinical nurse specialist. So they were added in for 2025 for attribution, and you'll see that they're changing that information now. This is going to be real important for ACOs because these beneficiary eligible patients weren't actually lined up with very well to their assigned beneficiaries. Now, with this, what they're planning on, what it really is going to account for is now there's going to be 85% overlap in these programs. So you'll or in these lists. So you'll be able to see that there is more or less most of your patients that you're attributed to, you'll also have on your Medicare beneficiary file for CQM reporting. It's now including those nurse practitioners, physician assistants, and clinical nurse specialists, and they're going to still continue to provide those quarterly lists using the same methodology. However, starting in the Q2 uh, report that should be coming out in the next month or so, they will now tag each or flag, they use the word flag, each patient is whether it will be part of the list based upon this proposal. If the proposal is finalized, then the Q4 list, which comes out in February of 2026, will only include those beneficiary eligible patients that are now attributed under the new method. So that will be your final list of who needs to be reporting for these quality measures. Other changes for the APP that are important, retroactive removal of the health equity adjustment for 2025. CMS is stating that it's duplicative of complex organization adjustment as well as the ECQM, MIPS, CQM reporting incentive. I think in the rule, what they said is that no group would have actually utilized the health equity adjustment to reach the goals needed because they all got one of the other two incentives, which would have overridden that. CAPS for MIP survey vendors now have to add the web base to their report, to their options for 2027, so not for next year, but for the year after. Web needs to be included in the way to do CAPS for MIP survey. And then an EUC policy is expanding over to ACOs for cyber attacks. So if a ACO is the victim of a cyber attack, they can take an EUC for the 20, or they can apply for an EUC for the 2025 performance year, and so on. All right, I'm going to go into some details here. The big changes here are that we're getting rid of 487, which is the social determinants of health measure. That's not going to be part of it. Otherwise, this is exactly the same as it was for previous years, but you could have this list for your viewing pleasure. Two, for the 2025-2026 calendar years, the only words I changed in this from my previous slide from last year is to take out the line that says including your health equity adjustment in here. Otherwise, these words are exactly the same for 25 and 26. For 27 and 28, there is only a slight difference from previous years is the number of measures, because in 2028 and so forth, in previous rule 487 was in there and it no longer is. Otherwise, these forms are exactly the same as what they looked at last year. Next, what does this mean to the clinician? No major changes on reporting options and structure. Changes in ECQM for breast cancer is probably the biggest thing. For those that are reporting on the ECQM, they're now going to be moving to add patients ages 40 through 49 into your bucket of what needs to be done. Only major change for scoring is the health equity bonus and the removal of the social determinant measure. Lauren, do you have anything you'd like to add on about MSSP?
No, I think you're good.
All right, cool. All right, we have a couple more slides and we're going to be out of here. I'm not sure we'll be able to get. I'm not sure if we'll be able to get to the finish line and be able to answer questions. So we will move on to answering your questions at a later time. But just to finish up here, how to set you up for success. HealthMonix software helps you select the measures, report, and see more into your score. We do have a US-based support and integration team here to help you maximize your quality reporting, as well as understanding where you need to go for your value-based care initiatives moving forward. In our MIPS Pro product, you're going to see some pretty nice enhancements as 2026 starts, but the ability in the system right now to understand your scores, know where the gaps are, understand what you're going to get from CMS, how you need to work the system to make sure that you are avoiding any penalties and maximizing your opportunity for at least avoiding the penalty and hopefully receiving an incentive. We do have a product called the MIPS Cost Analytics, which I'm going to throw over to Lauren to give a quick peek into what that can do for you.
So we recognize that the data that CMS provides for the cost category is somewhat sparse. At the end of the year, you get a report from CMS that gives you your scores on each measure that they've attributed to you and some information. And so what we've done is we've worked with CMS to get the data for all of your attributed patients, and not just the claims that you see, but all of the claims for those patients that really roll into the episodic costs. So that includes all the post-acute care or all of the additional care that patients are getting for chronic measures. And we roll it all together to hopefully give you a better insight in terms of what those cost measures are that are getting attributed, including the new ones. And then you can see kind of the overall scores, and then you can drill into like which clinicians are getting the episodes attributed, what services are going into each one of those episodes, how is risk adjustment occurring, and really looking at the data from the perspective of what can we do to do better. And that's all I'm going to say here, but we feel that a lot of people have gotten a lot of useful insights in terms of, how those measures are being calculated and what they can do to change.
Great. Thank you very much, Lauren. And just to finish it out, just an example of what our analytics tool looks like. So this allows us to dig into more information outside of your traditional MIPS reporting capabilities and allows you to really attack those gaps in care, whether they are patient independent or provider sourcing. Our analytics tool allows you really to dig into trends and into information that you have. If you need to contact us or you'd like to contact us, you can reach out to me. Everybody should have my email. But if not, you could also reach out to our sales team here at sales-new@healthmonics.com. And that is our phone number that you could reach out to here. Before I hang up on here, for those that are utilizing our system, you do have access to our knowledge base, which is brand new for 2025. And the knowledge base allows you to really understand and look at videos as well as different opportunities to help with improvement on score and so forth. So if you want the information to that, you can reach out to myself or the support team to make sure that you have access to that information. Stay tuned for our next webinar. I believe Lauren and I are going to try to put one together talking about the new ASM model and what that's going to mean for certain provider types and specialty types in the near future. And then come November, or November 1st, CMS says that the final rule will be coming out on November 1st. It's been a while since I've seen the time given that strict, so that'd be interesting to see that. So thank you very, very much for your time today. There were a ton of questions towards the ends and lots of thumbs up and claps. So you're making my day. And we will be getting back to as many people as possible and should be able to reply to you. So thank you for joining us today. Everybody enjoy the rest of your summer and we will talk soon. Appreciate it. Thanks,
Thanks
Lauren.
all. Take care. Bye-bye.
Bye.